All right, let's dive into the CLSI M100. If you work in a microbiology lab, you know this document is basically the playbook for antimicrobial susceptibility testing. But, it's about way more than just getting the right lab result. It's absolutely critical for keeping patients safe and making sure we're using our antibiotics wisely. So, we're going to break down how it all works.
So here's what we're going to cover. First, we'll get our bearings and figure out how to navigate the M100 tables. Then we'll talk about picking the right drugs to test and get a handle on the whole tier system. After that, we'll get into the nitty-gritty of breakpoints, look at some special testing situations, and wrap up with the super important rules that ensure our reports are both accurate and safe.
First things first, just navigating the tables. You've got to know the layout to use this thing right. Honestly, think of it as the roadmap you need for any accurate testing.
Okay, so the M100 is organized with a really clear logic. Don't worry about the tiny print here, just get the big picture. Tables 1A through 1J, that's your starting point. They give you suggestions for which agents you should even consider testing. Then you've got tables 2A through 2L, which have all the specific breakpoints for different organisms. And finally, tables 3A through 3L, that's for the real detective work, helping you hunt down specific types of resistance.
Now that we've got the lay of the land, let's talk about that first big decision, selecting the right agents. And this is not something you decide on your own. It's a real team effort, a conversation between the lab and the antimicrobial stewardship folks to figure out what makes the most sense for your hospital, for your patients.
So how do you actually choose? Well, it's a bit of a balancing act. You're constantly weighing how well a drug actually works in patients against the resistance patterns you're seeing locally. And you're always trying to avoid creating even more resistance down the line. On top of all that, you have to think about practical stuff, like FDA approvals, what the latest guidelines say, and yeah, even cost. It's a complex decision for sure.
To make things a little easier, the M100 has this really clever concept called equivalent agents. Basically, these are drugs that are so similar in how they work that their test results are almost always the same. And the best part? You only have to test one of them to confidently know the results for the others. I mean, that is a huge win for efficiency in the lab.
And here's what that looks like in the real world. For an organism like Enterobacterales, if you test cefotaxime, you automatically have your answer for ceftriaxone too. You'll spot these in the tables because they're literally joined by the word or. It lets labs be way more strategic with their testing.
All right, now for what I think is one of the most powerful stewardship tools built into the M100, the test and report tiers. This isn't just about what to test, but about how and when you report those results. It's all built around a strategy called cascade reporting.
So the system is broken down into these tiers. Tier 1 agents are your go-to primary drugs that you always report first. Tier 2 agents, you also test them routinely, but you might hold back that result. They're kind of your next line of defense. Tier 3 is for very specific situations in your institution, maybe for patients you know are at high risk for resistant bugs. And Tier 4, those are by request only. Think of them as the big guns you save for really complex cases. Oh, and there's also a special group just for drugs used to treat UTIs.
This whole tier system is what makes cascade reporting possible. Here's the idea. You only reveal or cascade the results for the bigger, broader spectrum Tier 2 drugs if the bug is resistant to the narrower Tier 1 drugs. And this is a total game changer because it actively steers clinicians away from just jumping to the most powerful antibiotics when a simpler one would work. It's a key tactic in fighting resistance. Let's make this real with an example. Say you have Klebsiella pneumoniae. If it's resistant to the Tier 1 drug, ceftriaxone, then the report will cascade and show the result for the Tier 2 drug, cefepime. But if the bug was susceptible to ceftriaxone in the first place, that cefepime result might just be hidden completely. You can see how this builds a kind of decision-making logic right into the report to encourage better prescribing.
Okay, so we've got the strategy down, but what do the results actually mean? To really get it, we have to decode the language of susceptibility. And that means understanding two key concepts, breakpoints and interpretive categories.
First up, the breakpoint. You can think of this as a line in the sand. It's a specific value, either a concentration of the drug, which we call the MIC, or a zone of inhibition size that separates one category from another. If your test result falls on one side of that line, the organism is susceptible. If it's on the other, it might be resistant.
That breakpoint is what lets us assign an interpretive category. And listen, this isn't just a random lab label, it's a clinical prediction. These categories, like susceptible or resistant, are built from a ton of data. Lab results, how the drug acts in the body, and results from actual clinical trials, all to predict whether or not the antibiotic is actually going to work for the patient.
Let's compare two of the most important categories. Susceptible is pretty straightforward, right? It means the drug should work at a normal dose. But susceptible dose-dependent, or SDD, is so important and a bit more nuanced. It's basically a yes, but. It's telling the clinician, hey, this drug can work, but only if you change the dose. Give a higher dose, give it more often, or run the infusion over a longer period of time.
The other two big ones are intermediate, which is kind of a buffer zone where the outcome's a little uncertain, and resistant. And that's a very clear signal that the drug probably isn't going to work and you're likely to see clinical failure.
Now, as we know, not all resistance is simple. Sometimes you have to do some extra digging. So for our next section, we're looking at more specialized testing scenarios. We need these extra tests, supplemental, screening, and surrogate tests, to catch specific resistance mechanisms that our routine tests might miss.
So here are the main types of tests in our toolbox. You've got your routine tests, your everyday workhorses. Then you bring in a supplemental test when you need to look for a very specific resistance mechanism. A screening test can give you a quick hint that something might be going on. And then you have surrogate and equivalent tests, which, as we've seen, are just really smart ways to use one drug to tell you about another.
This table shows a few key supplemental tests. Take the ESBL test, for example. It's designed to find enzymes in bacteria like E. coli that can destroy some of our most common antibiotics. Finding this one specific thing is a huge deal because it completely changes which drugs are on the table for treatment.
Surrogate tests are another one of those smart shortcuts. The classic example is using cephalosporin to screen for MRSA in staph species. If that cefotaxin test comes back resistant, it's an incredibly reliable sign that the bug has the MECA gene, making it resistant to methicillin. You test one drug, and you get this powerful answer about a whole class of other antibiotics.
Okay, let's wrap this up by talking about the safety nets. Because all this fancy testing means absolutely nothing if the final report that goes to the doctor is wrong or misleading. And that's where the M100's rules on quality control and its critical warnings are just so essential. The M100 has these warnings that are absolute, hard stops. They point out specific bug and drug combinations that might look susceptible on the agar plate but are known to fail in actual patients. For instance, you should never report Salmonella as susceptible to a first-gen cephalosporin, because even if it looks like it works in the lab, it often fails in treatment. These warnings are there to stop labs from accidentally sending a dangerously misleading report.
And that really brings us to the final thought here. The CLSI M100 is so much more than just a book of instructions. It's a whole framework for thinking critically about antibiotic resistance. So the real question to leave you with is this: how can applying these rules in your lab change your role from just someone who produces data to someone who actively helps guide clinicians to the best possible treatment for their patient every single time?